I am Dr. Kazmi, a neurologist and hospice medical director for Hospice of Havasu. I do want to discuss hospice admission guidelines today. I would like to educate physicians, nurses, and others who are involved with the hospice and palliative care. First, I want to clarify that these are guidelines, not the criteria. You need to learn them well and implement them. If you are a physician, make a referral. And if you are a nurse, make the good documentation so that we can improve the quality of our dying patients. There are few things which are must have for a hospice admission. One is terminal diagnosis. Two, the life expectancy should be less than 6 months. 3, certified by 2 physicians. 4, patient and family give consent. DPOA if patient is not available. And physicians can learn this and try to implement these guidelines into their practice. A patient can choose any physician to be his attending. Patient could consult another physician for secondary diagnosis, not for the primary diagnosis, and the primary diagnosis is the one which he was admitted for. To learn and to have documentation, we need to have some scales, one of which is palliative performance scale. Most of us know about the Karnofsky scale, and palliative performance scale is the scale which runs from 0 to 100. 100 is normal, 0 is dead. 80 is normal with some disease process and reduced or normal intake. 70 is reduced ambulation, but he is able to care for himself, but unable to work and has some disease process. 60, reduced ambulation, able to care for most of the needs, but occasionally require assistance. 50 means he's sitting in a chair or lying down. 50 means almost flat. But 40 is really flat. He's in the bed most of the time. So 50, he is sitting or laying down, needs considerable assistance, and he has extensive disease process. 40 means he is laying down in the bed, but able to feed himself. He is disabled and require assistance in almost all ADLs, that is, activities of daily living. And he has reduced intake. 30 means unable to feed himself. He's totally bedbound and severely disabled and has extensive disease process. 20 is totally bedbound, very sick, and has extensive disease process. 10 is totally bedbound and total care. 0 is dead. So recap that. 40 means he's flat in the bed and unable to do any of the activities, but able to feed himself. 40, he is able to feed himself but flat. 30, he is unable to feed himself and he is flat in the bed. So remember those. Another scale is a FAST score, Functional Assessment Staging. 1 is no difficulty. 2, subjective forgetfulness. 3, difficulties at work and organizational activities. 4 difficulties with complex tasks and activities of daily living. 5 require help with ADL. 6 impaired ADL with incontinence. So 5 requires help with the ADL, 6 ADL requirement plus incontinent of urine and stool. 7A is a speech limited to 6 words. 7B is speech limited to single word. 7C unable to ambulate. 7D inability to sit. 7E inability to smile. 7F unable to hold the head up. So 7A and beyond, they qualify for hospice and palliative care. 7A is speech limited to 6 words or less. Another scale is NYHA criteria, New York Heart Association classification. 1 is no limitation, 2 is mild disease, 3 is moderate disease, 4 and beyond they qualify for hospice. So NYHA criteria 4 means he is unable to carry out any physical activities without discomfort, and is symptomatic cardiac insufficiency at rest. So NYHA criteria 4, where he is severely disabled and unable to do any of the activities without discomfort, chest pain or shortness of breath, etc. Another scale is a descriptive scale. I came up with a mnemonic, MMNPE. M stands for mental status, second M stands for mobility, N stands for nutritional, P for pain, E for endurance. The scale is 1 to 5, 5 being normal. So higher the descriptive scale, the better the patient is. On mental status examination, 1 means he is comatose, 5 means normal. Mobility, 1 he is unable to turn in bed, 5 he is up and around. Nutritional, 1 no fluid intake and not eating. 5 means he eats and drinks normally. Pain, 1 means pain is 9 or 10 on the scale of 0 to 10. 5 means pain is 0 to 2. Endurance, 1 needs maximum assistance. 5, he does not need any assistance. ADL is activities of daily living. At least they need to have decline in 2 or more ADLs. I came up with a mnemonic for ADL is A, B, C, D, E, F. Ambulation, bathing, continence, dressing, elevate, that means he is unable to transfer, and feeding. Activities of daily living graded on 1 to 4. 1 being completely dependent, 4 being independent. So ADLs are ambulation, bathing, continence, dressing, elevate, that means transfer, and feeding. The scale is 1 to 4, 1 being completely dependent. So higher the ADL number is, the better the patient is. There are some core measures or core indicators which apply to all disease-specific guidelines. So no matter what disease they have, document these things, which will really make a difference. General physical decline in patient's condition is important, and we need to document that. Palliative performance scale, which we went over, should be less than 70%, but for other diseases, it should be less than that. FAST score for dementia should be worse than 7A, 7A and beyond. decline in functional status, at least 2 or more ADLs, that is A, B, C, D, E, F, ambulation, bathing, continence, dressing, elevate, that means transfer, and feeding. And they need to decline in descriptive scale, which we just discussed. He may have stage 3 or 4 pressure ulcer. So document those. And other measures are multiple hospitalization, a physician's office or ER visits, declining enteral and parenteral support, multiple comorbidities, rapid disease progression, patient is rapidly declining, and he might have life-threatening complications, with emphasis on positive and negative clinical findings is important. Worsening of the clinical status, worsening sign and symptoms despite excellent treatment, recurrent infections, and bed sore or sepsis. Weight loss more than 10% in 6 months, 5% in 3 months, despite the fact that he is eating and drinking fluids. Weight loss can be documented with measuring the weight or mid-arm circumference or abdominal girth or skin turgor or visualize weight loss or ill-fitting clothes or loose dentures or visual description of a family member. So you need to at least document that. That will help you. Decrease appetite, decrease fluid intake, patient's desire and will to die should be documented. Serum albumin is less than 2.5 gram per deciliter. It doesn't mean that you need to do the labs, but if they were admitted to the hospital and had the labs, look at them. If the serum albumin is down less than 2.5 gram per deciliter, that's important. Dyspnea at rest, increase respiratory rate using abdominal or accessory muscles, and the vital capacity is less than 30%, needs O2 at rest, and the patient is declining artificial ventilation. Patient might have intractable cough, nausea, vomiting, diarrhea, poorly responsive to treatment provided. Severe edema, fluid retention, peripheral, pleural, pericardial, and lymphatic spaces are showing that the patient has edema. So document that. Patient has weakness and his systolic blood pressure is less than 90, or patient has severe postural hypotension. Please try to document all comorbidities. Comorbidities are the diseases which are present in addition to what you admitted the patient for. Document clinical regression. Document declining in functional status of the patient and structural status of the patient, and declining in ADL and descriptive scale. Change in level of consciousness, worsening of other symptoms, dysphagia, leading to recurrent aspiration and or inadequate oral intake shown as decreased food and fluid intake. All these are important. The labs are not important unless the patient was admitted to the hospital and then being transferred. And if they do the lab, look at them. We in hospice sometimes do the finger oximetry to document the O2 sats. Calcium, creatinine, LFTs could be done to document the regression. tumor markers such as CEA and PSA, CBC for anemia, and PT-INR if the patient is on Coumadin. Serum sodium and potassium level in certain patients may help. If you have done some labs, take an action. Take an action on any other test you do. Now we are going to a disease-specific guideline. First of all, you need to learn that all the core measures or core indicators I discussed, document them also. So sometime I'm going to repeat so that you get the idea that those are important things. His PPS is less than 50%, and the patient is mostly in the bed or maybe sitting up. As I told you, flat means 40. That means patient is in the bed all the time. Dependent on more than 2 ADL. Descriptive scale of 20 or less. BMI less than 22. Patients and family and DPOA wants hospice care. Refusing curative care. Refusing parenteral and enteral nutritional support. Not responding to any nutritional support. His weight is decreasing, and he lost more than 10% in 6 months and 5% in 3 months. Patient has a desire and a will to die. He has infections, aspiration, UTI, sepsis, frequently. Unable to maintain sufficient calories or fluid. Serum albumin less than 2.5 gram per deciliter. He might have a stage 3 or 4 pressure ulcer. And the patient in the recent past has increased ER visits, multiple hospitalization, multiple physician and office visits. So document all comorbidities and emphasize the core indicators. That's important. That is adult failure to thrive or debility unspecified. Both have similar guidelines. Next one is malignancy. Diagnosis is confirmed through pathology or radiology. Patient has cancer with poor prognosis, and the cancers which has poor prognosis are brain and pancreatic cancer and a small cell CA which is diffuse of the lung. Patient no longer receiving or declining curative therapies. Progression of the disease with metastasis. Clinical finding of malignancy with widespread progression, and the disease is aggressive as evidenced by increased signs and symptoms, labs, radiology, pathology, and the old records. Evidence of end-stage disease, and patient has metastasis. Palliative performance scale is less than 70%. ADL 18 or less, and descriptive scale is low also, maybe 20 to 25 or less. Hypercalcemia. Calcium is more than 12. Weight loss of 10% in 6 months, 5% in 3 months, and the patient has symptoms of advanced disease such as nausea, ascites, effusion, and patient may be needing multiple transfusions, etc. If the family wants chemo and radiation for palliative purposes, for preventive purposes, or to control the pain, then the team has to decide. So he has to have metastasis, poor prognosis, and he has most of the core indicators. ALS, rapidly progressing signs and symptoms of the disease in the preceding 12 months. For ALS guidelines, patient has poor prognostic factors such as ability to breathe, ability to swallow, ability to sit in the chair, and he is mostly bedbound and unable to walk. And he is wheelchair to bedbound. And he has terminal stage of ALS. His vital capacity less than 30%. And significant dyspnea at rest with use of abdominal and accessory muscles, or patient has orthopnea. Paradoxical abdominal motion, respiratory rate more than 20 per minute, requires oxygen at rest, reduced speech and vocal volume, barely intelligible speech, weak cough, sleep disorder, disordered breathing, frequent awakening, headaches, confusion, anxiety, critical nutritional impairment leading to dehydration, aspiration, and he has nausea, and he has multiple other comorbidities. Declining assisted ventilation, and the complications are infection, sepsis, decubitus ulcer, PPS less than 50%, decline in ADL, and the descriptive scale. And for descriptive scale, could be less than 21 for ALS. Next one is cardiac diseases. Patient has congestive heart failure or coronary artery disease with NYHA class 4. That is significant disease at rest. So for cardiac problems, make sure that the patient has significant decline in the condition and he has NYHA class 4. Dyspnea and angina with minimal physical activity. That is class 4, NYHA criteria. Patient has been optimally treated with diuretic, ACE inhibitors, vasodilators, hydralazine, and nitrates. Patient has angina at rest, not responding to nitrate. He is not a candidate, or the patient and the family declining curative and invasive and surgical therapies. Discomfort with minimal physical activity. Symptomatic at rest, and he is symptomatic despite maximal medical management. Arrhythmia resistant to treatment. Ejection fraction less than 20%. For cardiac diseases, NYHA criteria class 4 or worse, and ejection fraction is less than 20%. History of cardiac-related syncope, cardiac-related cerebrovascular accident, and patient recently had cardiac resuscitation. His PPS is less than 60%, ADL less than 18, descriptive score is less than 20. Next one is diabetes. The patient has diabetes for more than 20 years. Severe vascular disease or vascular complications including CVA, cerebrovascular accident, MI, congestive heart failure, and angina. Amputation or ulcer due to vascular complications. Severe hypertension, frequent infection, PPS less than 60%, ADL 12 or less, descriptive scale 21 or less. So in diabetes, they need to have disease process for more than 20 years, and they have vascular complications and poor PPS, ADL, and descriptive scale. HIV and AIDS. Patient CD4 count is less than 25 per ml. Viral load is more than 100,000. And he has wasting syndrome with the loss of lean body mass more than 33%, or he has 10% weight loss. And person has chronic persistent diarrhea for more than 1 year, not receiving TPN, and patient has opportunistic infections. Patients not receiving any active treatment, and patient develop AIDS dementia complex, and patient's age is more than 50 years. The comorbidities associated with HIV and AIDS are CNS or systemic lymphomas, MAC, bacteremia, unresponsive to treatment, and patient has progressive multifocal leukoencephalopathy, PML. Patients have cryptosporidium infection. Patient has visceral Kaposi's sarcoma. Patients have refractory toxoplasmosis and renal failure also complicating the issue, and patient is not on hemodialysis. PPS is less than 60% and ADL 18 or less, and descriptive score is 20 or less. So most of the time ADL less than 18 and the descriptive score is less than 20. Other patients who we admit have liver disease. Patient has end-stage liver disease, and he has abnormal liver function test, abnormal coagulation, INR more than 1.5, or PT, ProTime, more than 5 seconds over the control. Serum albumin less than 2.5 gram per deciliter, and patient has refractory ascites, and he has history of spontaneous bacterial peritonitis, recurrent variceal bleeding, hepatorenal syndrome, hepatic encephalopathy, and PPS is less than 60%, ADL 18 or less, descriptive score is 20 or less. Other progressive issues are malnutrition, muscle wasting, and patient is still drinking maybe more than 80 grams of alcohol per day. And patient has hepatocellular carcinoma, hepatitis C, and hepatitis B surface antigen positive, and patient is declining in all aspects of his life. So that was end-stage liver disease. Neurological disorder, main thing is patient cannot talk, cannot walk, cannot take care of himself. And patient is unable to walk without assistance, needs assistance with ADL, and he has barely intelligible speech. Dysphagia leading to poor nutritional status. General decline of the patient. Disease progression. Emphasis on all core indicators, and patient is declining curative therapies, or curative therapies are not available, and declining assisted ventilation. And patient may have complications such as pneumonia, UTI, sepsis, and decubitus ulcer. That is for all disease processes, those complications, pneumonia, UTI, sepsis, and decubitus ulcer. So you can add to any of the diseases. Dementia, most of our patients have Alzheimer's type dementia. FAST score is 7A or beyond. Patient unable to walk without assistance. Patient has urinary and fecal incontinence. Speech limited to less than 6 words. Unable to dress without assistance. Difficulty swallowing, and patient is eating poorly and unable to maintain fluid and calorie intake. Unable to sit up or hold head up. Insufficient fluid or food intake with weight loss. In the last 12 months, patient has aspiration, recurrent infection, fever, decubitus ulcers of stage 3 or 4, and patient might have sepsis and UTIs. Patient is losing 10% of his body weight, and albumin is less than 2.5 gram per deciliter. Patient continued to decline, and that was for dementia. Next one is CVA. Patient is either chair or bed bound, and the paralysis is due to large anterior or bihemispheric infarct, or basilar artery involvement, or bilateral vertebral artery occlusion. Dysphagia, and patient has decreased appetite, decreased fluid and food intake, and he is losing weight more than 10% in 6 months and more than 5% in the last 3 months. Again, albumin is less than 2.5 gram per deciliter. For CVA, age is more than 70. Aspiration precautions should be taken, and he failed speech and other measures to improve the aspiration, and patient might have post-stroke dementia, poor functional status, PPS less than 40%, ADL less than 18, descriptive score 20 or less. And patient has complications such as pneumonia, UTI, sepsis, and decubitus ulcers. Patient who has hemorrhagic infarct have more than 20 ml infratentorial and more than 50 ml of the blood in the supratentorial area. And if they have a midline shift, it may be more than 1.5 centimeter. And the stroke involving more than 30% of the cerebrum. Patient declining surgical intervention and curative therapies, or patient may not be a candidate for that. So that is for CVA. Next one is coma. In the last year or so, patient progressively declining, and his PPS was less than 60%. ADL 18 or less, descriptive score 20 or less. And now he became comatose. On the day 3, showing abnormal brainstem responses, absent verbal responses, absent withdrawal response to pain, and serum creatinine more than 1.5 gram per deciliter. So patient is comatose without any response. And make sure that he does not have drugs on board causing the coma. Next one is pulmonary disease. Disabling dyspnea at rest. Dyspnea is with little or no exertion, and they have little or no response to bronchodilators. Dyspnea with minimal activity for pulmonary diseases or COPD or emphysema. And the patient is O2 dependent, and he may be hypoxemic at rest on room air. PO2 is less than 55, and O2 sats are less than 88%. FEV1 is less than 30%, even after bronchodilators. Multiple pulmonary medications, recurrent pulmonary infection, weight loss of more than 10% in the last 6 months, and he has resting tachycardia of more than 100 per minute. Patient has decreased functional capacity, and he is from bed to chair, chair to bed, and he's fatigued all the time, and he has cough, and he has increased ER visits or office visits or hospitalization for lung infections or respiratory failure, and patient doesn't want to do any more. Karnofsky scale is less than 60%, ADL 18 or less, and descriptive scale is 20 or less. Patient developed core pulmonary, right heart failure, unintentional progressive weight loss. So pulmonary diseases, they need to exhaust the medical management, and he has disabling dyspnea at rest or with minimal activities, and patient has tried most of the medications. For renal disease, patient would like to continue to be on hospice, and he does not want or refuse dialysis or transplant. And patient for renal diseases have signs of uremia, confusion, nausea, pruritus, and restlessness. Chronic or acute illness that precipitated renal failure, creatinine more than 8, but for diabetes is more than 6 milligram per deciliter. Creatinine clearance is 10 cc's per minute, but for diabetes is less than 15 cc's per minute. So creatinine above 8 and creatinine clearance is less than 10 for renal disease. Creatinine more than 8, creatinine clearance less than 10. And patient has oliguria, less than 400 cc's of urine per day. Patient has hyperkalemia, more than 7.0 milliequivalent per liter. Other issues are uremia, uremic pericarditis, and hyperkalemia more than 7, and fluid overload. And the Karnofsky scale may be less than 60%, and ADL 18 or less, and descriptive scale 20 or less. And patient has other comorbidities in addition to renal issues. Now we admitted a patient, and he was on hospice for some time, and you come to a decision whether we need to keep the patient in the hospice or not. So you need to decide, depending upon all the comorbidities and disease-specific criteria as I discussed, and if the patient does not meet the criteria, so he is not eligible for hospice, and he improved and stabilized, then give them 2 days of notice and make sure that you follow the safe discharge instructions. Make sure his patient is safe to be discharged. But if the patient originally qualified for hospice but stabilize and improve while under hospice care, yet have a reasonable expectation of continued decline with life expectancy of less than 6 months, should remain eligible for hospice. Those patients are different. But if you want to discharge, you can give 2 days of notice provided you take all the measures to have a safe discharge. To the nurses and staff which are working for hospice and palliative care, I suggest that they need to paint the picture. They need to have all the things they notice, they feel, they see. They need to document them. If the patient has multiple infections, multiple falls, or decubitus ulcer, and he's not eating, he's not taking enough fluid, and he's losing weight. And if you find something else which is important, then write them down so that patient will qualify for hospice provided he continue to do poorly. I strongly urge physicians and the nurses to learn and make a difference in the life of your terminal patient. It's very important. And if you have questions or comments, send it to Hospice of Havasu, Lake Havasu City, Arizona. Thank you. God bless you.